Welcome to the American Academy of Emergency Medicine's Justice, Equity, Diversity, and Inclusion section webinar, The Rank List, Finding Your Best Fit. My name is Dr. Kristen Fontes. My pronouns are she, her, and I will be moderating tonight's session. Tonight's program will be recorded and uploaded to the AAEM JEDI website within 24 hours. I'm curious if we could have our audience members just take a moment to say hello, tell us where you're logging in from in the chat. I'd love to be able to greet you. These sessions are meant to be interactive. I know we have a webinar format for this one, but we do want to make it interactive. So please use the Q&A or the chat functions if you have a question or a comment. Please know this is a safe space as well. We welcome and encourage your participation, and we intend to foster open and respectful dialogue. Hi, Joseph, welcome. Thank you for coming. Hello, Andy, welcome. So Cal, me too. All right, we'll give everyone just another minute. Feel free to say hello in the chat. Let us know where you're calling from. I apologize, my AirPod keeps falling out. And then in just a moment, we'll move on to introducing our panelists, and we'll get started. Hi, William. Thank you for being here. All right, well, why don't we go ahead and we will have our panelists introduce themselves to you now. Panelists, as I call your name, please go ahead and turn your video on, unmute yourself, and tell us a little bit about you. We will start with Dr. Brown.
Hello, everybody. Really great to be here, and I'm really excited. Sorry, this is my cat. Very excited to be here. My name's Dr. Brown, but you can call me Cortland. I am a current faculty member at Carolina's Emergency Medicine in Charlotte, North Carolina. I did residency at UCSF, where I was chief resident, med school at Yale, and undergrad at University of Chicago. I'm currently our department's vice chair for diversity, equity, and inclusion, and I'm also our clerkship director for our healthcare disparities in emergency medicine 4th year away rotation. In addition to that, I've really been involved in AAEM JEDI section, as well as SNMA, where I serve on the Strategic Planning Council, and past roles have included National Vice President. Thank you so much for hosting this.
Great, thank you. We will move on to Dr. Sanchez.
Good evening, everyone. My name is JP Sanchez. I serve as the Interim Executive Diversity Officer for the School of Medicine at the University of New Mexico, as well as the Executive Associate Vice Chancellor for Diversity, Equity, and Inclusion at our Health Sciences Center. Following Dr. Brown's lead, I'll just share, I grew up in the Bronx. I'm what some people would call a Bronx Puerto Rican. Both my parents were born in Puerto Rico. And beyond identifying as Puerto Rican and Latino, I also identify as gay. Did residency at Jacobi Montefiore in the Bronx. So I stayed pretty local, but now I'm in the state of New Mexico. Good meeting, everyone.
Sorry, I was muted. Thank you very much. We will now bring on Dr. Politis.
Hi, everyone. My name is Greg Politis. I'm an associate professor of emergency medicine at WashU in St. Louis. I am probably, I guess, a little bit inbred WashU. I went to college here and then I went to med school in Chicago and then came back and did residency here and have, this is actually my 20th year now on faculty. So during this time, I've worn a lot of different hats. I was a course director in the medical school for the first, third, and fourth year classes. I've been an assistant residency director. I currently serve as one of the chairs of one of the regional subcommittees, the subcommittee that looks at applicants to the medical school from the Midwest. And I'm involved in AAEM as the vice chair of the International Conference Committee as well. And so I do a lot of mentoring and advising, and I actually run a course on here at WashU called Med Prep that is a large pre-health course that about 90% of the pre-med students take. It kind of takes a student from the day they start college to the day they become a board certified physician. And it's also tied in with a shadowing course that the students do when they're juniors and seniors. So we talk a lot about residency issues, even at that stage, about how medical students decide what they want to go into and how they decide what a good fit. So I thought this was a great venue to talk with you all. And I've done a lot of mentoring advising in this area. So I look forward to answering any questions you may have, and also hearing the perspectives of our other guests. So thank you.
Okay, thank you very much. We will move on now to Dr. Ely.
Hi, everyone. I'm Dr. Ely. You can call me Alyssa. My credentials are nowhere near as exciting as everyone else's. I'm actually a second-year EM resident down in Miami at Mount Sinai on Miami Beach. Interestingly enough, I started out as a surgical resident and then sort of saw the light and switched over. I had a whole life before med school, so I think a lot of my perspective is very much colored by the fact that I sort of wandered through life until I found what it was that I wanted to do and who it was that I wanted to be. I am biracial. My mom is white, my dad is Black. I also identify as queer. And so my big goals in emergency medicine are just trying to diversify residency programs and provide support and letting incoming residents know that there are so many different shapes and sizes and versions of emergency medicine physicians, and that this field is here for everyone.
Great, thank you so much. And lastly, but certainly not least, Dr. Noble.
Hi guys, good evening. Thanks so much for joining the call. My name is Ariel Noble, and this is Evie. If you can see her, she's sitting on my lap here, my one-year-old daughter. And so certainly adding to the diverse faces of emergency medicine. I am a first-year resident and single mommy to this 13-month-old little one who's gonna make all the noise. I hope she settles down tonight. I'm originally from North Little Rock, Arkansas. Grew up in Arkansas, did an undergrad and my master's program there, and then left the States to attend St. George's University. So I'm also an IMG. I don't have a ton of knowledge to share, but I hope that I can share enough about my selection process tonight with you all, being kind of new to it and just out of med school and recently becoming a resident. And thankful to be here tonight. Thanks so much for having me.
Okay, thank you so much. So why don't we just go ahead and dive right in. So each of our panelists was asked to submit a couple of questions that they would like to cover. So I will use those to help moderate our discussion. Now, I also have questions that were submitted by our attendees at the time of registration. So we'll weave those in as well, try to get through as many as we can in the time that we have together. So we'll start with a broad question. I'll ask it in a few different ways, because actually Dr. Politis and Dr. Noble kind of asked questions that are fairly similar. So I'll direct the first set of questions to you, but anyone, please feel free to respond at any time. So one question is, what aspects of an EM program do you feel are most important in choosing a residency program? Looking back at your own match experience, what influenced your choice in ranking your residency programs? What would you like to share with students about when they rank their programs?
Dr. Noble, would you like to go first?
Sure. I'd love to share. I think it'll sound really cliche, but I think the process for me was really personal, and the factors were not at all really about the program so much as it was about who I am as a person and what I value. I valued my family, or I still do value my family, and I wanted to be in a distance that was near enough that I could see them, far enough that maybe I didn't see them all the time. I really wanted to still have that community. Residency is a very challenging time, probably maybe one of the most challenging times that you'll have in your life. And I can say that I know that for sure, being almost 8 months through. It has been, the learning curve is tough. The hours are tough, and so you should have a good support system where you are. So the first thing for me was, do I have community there? And outside of having a community, family-wise or friend-wise, you want to be sure that you have community with the people in your program. Are they going to advocate for you? Do you have someone that you can talk to when you're connecting with these individuals via Zoom calls, as much as you can connect virtually? Do you feel that connection? And do you feel like these are people who are going to support you when it gets tough? Because it will. Outside of location, community, I think that at the end of the day, the training programs look very similar, but you do want to be sure that you'll get a really good exposure to pathology, a really good diverse set of patients, range of procedures. You want to be somewhere where you'll get, good training. And I was very fortunate to match in Mississippi at the only level 1 trauma center in this area. Outside of that, people go either Louisiana or Tennessee, but this is the only one like it here in this area. And so I kind of get the range of patients. I get patients from everywhere. And I think it's really important in this time, especially when we're in the ED, not seeing a ton of patients sometimes, unfortunately. That's improving, but it's really important that you get to see a lot and do a lot wherever you go. So those are kind of my big 3.
Yeah, I would second that. I think that number one, I think most programs that you go to are going to offer you what you need to be a really good emergency physician. But I think that gestalt, that feeling of fit, is so important, because I think more than any other point in your training, residency is a time where you're really going to rely on the people that you work with. You're going to be working long hours. You're going to have these shared experiences, and I almost feel like, for our residents, going out after an evening shift just to get something to eat for an hour before you go back home, and they get back up and do it again, I think it's really important, because even if you're not talking about work, if you just have this shared experience of, where you feel like you were just, operating on that red line, where you just feel like, oh my gosh, how long more can I, have a busy day like this? I think that's really, really important. I think that sense of community is huge. I know when I came here and trained, one thing I liked about WashU is that we're one of the 2 major safety net hospitals, us and St. Louis University, for the city of St. Louis. And so I think I took a lot of pride, and still do, in the fact that we're able to offer world-class care to people who otherwise would fall through the healthcare safety net. And of course, we all see that in the emergency department, those that weren't able to get into a primary care doctor who present with an advanced stage of cancer, or, some uncontrolled medical illness that they just didn't have the great follow-up that they needed. And so I think, that's something that I think special too to emergency physicians, is that I think we really do take into account the whole patient. I mean, I think so important. I was talking to my resident the other night. It's been really cold lately here in St. Louis, down into the teens, and we had a patient that was kind of borderline, needed to be admitted, probably did not need to, but didn't have a place to go. Family was not answering the phone, and I said, this is really the time when we need to be creative and use that diagnosis that we can, to get this person in overnight, because otherwise they're not going to do well, and so I think even our colleagues, up on the floor, they understand that when we say, look, it's more than just this person's disease. We need to figure out a place for them to be. And so I think we really take pride in that. I think the one thing about our program that I think a lot of programs have that you should look into too is, I think that residencies that offer that kind of nice balance between autonomy and supervision is really important, where you're allowed to kind of extend yourself, but not get into a danger zone where you feel like you're not being supervised properly, but yet also gives you the ability to kind of extend yourself. And I think that's really an important thing. And so if you can get a feel for that, from the programs, because residency is a very steep learning curve. And I think that, medicine is one of these things that you feel like you're always kind of starting at the bottom of the totem pole every time. You start as an intern and it's scary, and you've got so much to know. And then our residents, when they go into their second year, they're in the ICUs a lot. And so when they become a third year, early on, they're kind of like the precocious 12-year-old child who kind of knows it all and tests you with the evidence and all that kind of stuff. And we know this pattern. I mean, I went through it. I think we all did, and it's kind of nice to know that they go through this progression, and that's okay. That's part of your kind of maturation as a physician. So, but I think, the fit's really, really important. And, because this is probably going to be the most impactful part of your entire, training pathway up to this point is your residency. So you should be excited. It's I think the most fun part's coming up too. So
I'd love to just highlight and jump on. So I think two of the biggest things for me were community. My answer is very similar to the first answer, but community and the patient population. So I went to San Francisco because I knew I'd be surrounded by like-minded individuals. The program was a very warm and fuzzy program, which was exactly what I was looking for. And then the patient population. So I, just being very real right now, like I do not do well with VIP patients or quote unquote VIP patients. I just don't. So these are the patients that come in and maybe they're CEO somewhere and they call multiple doctors before arriving. So they're coming and they expect the MRI for their toe pain. And so I knew that I didn't want to be at a program where that was largely the patient population. And pretty much every program that you'll interview at, they will say that they have a diverse patient population, but it's important to ask in what way. Because if it's that, all of their patients are white, but some have more money and some have slightly less money, that may not be the diversity that you're looking for. And so really narrowing down what patients you want to work with, and does the program have that?
Right. Thank you, everyone, for your input. How about from the program's perspective? We had a question from one of our audience members, Bhakti, who asked, can you shed some light on what qualities residency programs look for in EM applicants, and what type of people excel as EM physicians?
I think that is an excellent question and sort of perfect timing. We just had sort of our rank list party, and I will say one of the most important things is just your overall attitude. The learning curve in every specialty is steep, but EM's a little bit different in the fact that we have to know something about everything. And so your willingness to just sort of take what comes at you and move forward with grace and humility with a positive attitude will make a world of difference. And for both, residency faculty, as well as your co-residents, your ability to be resilient and be positive in the face of that very steep learning curve makes such a big difference. And, we definitely have interviewed people who maybe their board scores are not through the roof, but the impression they made while they rotated, how willing they were to just learn everything, try everything, made such an impact that irrespective of their board scores, they move very highly up the rank list. Because at the end of the day, it's really about your willingness to take on all that knowledge that is going to be thrown at you. And it is going to be thrown at you. You just sort of get dropped in the deep end. In EM, I think my first day, they were like, all right, let's go intubate this patient, right? So there's just, you just have to go, and you have to have that attitude that you're just willing to go. And that's so, so important. And then I think the other thing is just your willingness to be somewhat autonomous and independent and a little bit fearless. Same thing, EM is, we don't always have that nice safety net there in EM. A lot of times we're in situations with low resources, very little information, and very little time. So having that little bit of fearlessness, I also think stands out quite a bit.
I definitely agree with that. I would add being a team player and striving in team environments, because I think in emergency medicine in particular, you rely so much on your nurses, your respiratory therapists, your clerks, everybody working in the department. And so you have to have that team spirit. I would say in terms of what programs look for, it really depends on the program. So, there's definitely going to be some research programs that want you to have, done some research in the past. There's going to be some programs that are much more advocacy based. And so I would say, look at the program's mission as well as their vision on the website, and you can get at least somewhat of a sense from that. And then you'll get a little bit more on the interview day. But definitely don't let any part of your application completely dissuade you from emergency medicine. So I passed step 1 by like 3 points, same with step 2, same with step 3. So my board scores are terrible. And, there's certainly some programs that didn't interview me because of that, but there's a lot that did and saw, everything else that I had to offer. I'd also say that a lot of times people think that EM doctors are like very loud and we're just like all in your face and we like bike to work and we go hiking after work. It's like sometimes true, but there's definitely space for the more like quiet, reserved EM resident as well. And so don't let that kind of vision dissuade you. If that's who you are as a person, that's definitely more than welcome. And, we love that perspective.
Great. Thank you so much for those responses. I definitely personally can identify as not being the sort of hiking, cycling, skiing, everything type of person. I did mountaineer for the first time as a resident, but there was a lot of like influence there that did not come from within, but I'm glad I did it. Why don't we talk a little bit about types of programs? Now, Dr. Ely, you had mentioned, sort of differences that you saw or things that you want to reflect on when you're looking at community versus academic programs. And then I think also Dr. Politis, kind of looking at like 3 versus 4, certainly want everyone's perspective here, but that's kind of where I want to flow to next is, what to look at when you're trying to decide between programs that may be very different, sort of structurally, time-wise, et cetera.
In terms of the difference between academic versus more so community programs, this is something I wish I had known more about going into it. I started residency at a big academic center as a surgical resident. And in my mind, all emergency medicine programs were sort of the same and functioned the same way that these large academic centers do. And it really wasn't until I started interviewing and looking more into programs that I realized what the differences were. So one of the most important things for me that I realized while I was researching programs and applying and interviewing was that I wanted a place that was sort of a closed department, meaning that all the procedures and everything like that went through the emergency medicine residents first versus being consulted out to other specialties within the hospital. And so that was incredibly important to me. And what I realized is more academic programs tend to have more consultants, mostly because you have so many other residency programs within the hospital. So the learning really needs to be shared amongst everyone. And then most academic places do also have a little bit more of a research focus, which for me was not as important. I do some research, but I'm not big into clinical research or things like that. So when looking at the academic programs versus the community programs, I really had to decide where I wanted to put my time. And for me, I like to invest my time more so in the clinical side of things and the research side of things. And that actually really helped me narrow down my rank list quite a bit. I did interview at some 4-year programs. I don't know, I'm sure the attendings who are on can speak to whether or not they feel there's a difference in your level of training. Our program actually changed from a 4-year program to a 3-year program, maybe 6 or 7 years ago. And in talking to our faculty, they think everyone gets to where they need to be, but I have talked to some faculty who feel like those who did a 4-year residency were maybe a little bit more prepared because essentially you function as a junior attending your 4th year. For me personally, I did not want to spend that extra year. Like I said, I sort of wandered through life, went to med school a little bit later. So for me, it was more important to find a 3-year program, sort of get in, get out, and then be able to move on as an attending. but it very much depends on what you care about. If you are very into research, you really want to do, you know, some more involved fellowships, critical care fellowships, things like that, you might find that academic centers suit your needs a little bit better. If your plan is, you know, hey, listen, I want to be a community doc in, you know, high volume, high acuity areas, then you might be better served being in programs that are community-based programs where you're really working on like, hey, see those 3 patients an hour, get everyone moving. So just thinking about where you want to go in the future will really help you determine community versus academic for you.
Boy, that was outstanding. I don't know if I could add anything to that. That was wonderful. I would say the same thing. You know, I have advisees that wander between 3 and 4 year programs, and you know, there are some that are kind of like chomping at the bit. They want to get done, and they think, why do I need a 4 year program? And really, everyone doesn't. I mean, even our own 4th year residents sometimes say they wish maybe they had, you know, 3.5 years or something like that. I think it all does depend on what you want down the road. And the good thing is that you're really not limited either way, because if you want to do academics and say you want to go someplace that does have a 4 year residency attached with it, you can always do a fellowship after your 3 year residency. So you're not, you know, you're not really limited by either direction which you go. I also think that it is very important if you go to academic programs, some of the programs that are affiliated with you know, high research type places like WashU and all that. I think that's really good advice about finding out you know, who else is in the mix. One thing that we do pretty well here is that we have very clear delineations between what our residents do and what surgery does, for example. So we have a equal division of labor in terms of who runs the level 1 traumas and who's the person putting in the lines and who's doing the innovations and all that. So, and that's very, very important. But I do know some programs where that's not quite as clear, and where some places will have, you know, surgery come down and kind of take over. And I don't think you really want that. So I would recommend when you look at your programs, that's something you can find out oftentimes by the residents themselves. And I think they'll be honest with you about it. I don't think there's anything rude about asking. So can you tell me kind of what role do you play, say, in situations where other departments are involved? Do you feel like you get the autonomy that you need? I think most residents are going to be pretty open about that. At least I know ours would. And so I totally agree with that. And I think, you know, what you want is to go someplace where when you come out, you feel like you can do anything. And I think either program can afford that to you, but you might find that one feels like a little bit better fit. If you know, for example, that you don't want to do research, you know, some programs may have a research requirement, you know, may require that you complete some kind of scholarly activity. And so checking into that is important. And then likewise, if you do want that, you want academic medicine, finding what places kind of help you with mentorship and research and help you get kind of, you know, set up on getting involved in different kind of national committees and all that as a resident. So, yeah.
If I could just add something about academics, I chose an academic career right in medical school. But what I would just comment on as we talk about academic medicine and academic careers is that an academic career is not just research. Every department, whether it's emergency medicine, surgery, internal medicine, is obliged, is required, must meet the mission areas, all mission areas of a medical school. So you should consider not only whether you're interested in research, but how can you support the mission of education. And so all ER practitioners and residents are teachers. And as such, that's an important way to contribute. All departments also have to respond to outstanding clinical care. That's another mission area. 2 other mission areas that are becoming more pronounced and is especially important for many diversity applicants is DEI is a mission area. And so you can drive excellence in that way, and community engagement. And so I highlight all 5 because despite what sometimes is mentioned, all EM departments that are in academic medical schools either have 3, 4, or 5. At University of New Mexico, we've moved to 5 with metrics, expected metrics for everyone in emergency medicine, but also the dean is responsible for DEI metrics and community engagement. And I think for me, in leaving the Bronx and coming to New Mexico, it was important that part of the draw to come to New Mexico is that 12% of the population is indigenous, Native American, and 50% is Latino. So when we think about fit and a match, I think candidates who say, you know what, I want to learn about Native American health. I want to know what emergency medicine is like in serving the New Mexico populations, the inhabitants here, multilingual, Native American, Hispanic goes a long way. Rather than just saying, I'm interested in diversity, right? Well, you just got to go a little bit further to show that you've actually looked at the website, you know what the community is about, and then how are you going to drive excellence and have impact?
I think that's a great comment, because people do automatically, I think a lot of people make the instant association that academics means research, and it just doesn't. I mean, health policy, and global health and public policy, all of that, these are passions that you can do in emergency medicine, and academic programs are looking for people who have those passions. Very important. Yeah.
Great, thank you so much. That's a great discussion. So I think at this point, I'd love to just kind of open it up to all of our panelists. This is a diverse group of people. Everyone has their own unique lived experiences. And we know, and what's kind of been mentioned a couple times already, is that emergency medicine, like most medical specialties, continues to see underrepresentation of several groups. Certainly not including, but not limited to, people of color, women, and queer people. And I want to know, if you feel comfortable answering this question, tell us how your identity impacted your rank list. I mean, we've talked about trying to find community, trying to find people to connect to. Did that sort of fit in when deciding on where to rank programs based on how you identify?
It was very, very important for me. Residency can be a very lonely and isolating time, especially with COVID. So for me, it made it that much more important that I felt like I was going to have patients that looked like me. I was going to have faculty that looked like me, and honestly, co-residents that look like me. And I will say, I'm the only Black resident in our program, and so that has given me sort of an opportunity, I feel like, to broaden our program. That's really been one of my goals. And I'm able to do that because I have the faculty support that I do. And so knowing that faculty support was going to be there, I did all my research. I knew that there were queer attendings here. I knew we had Black attendings here. I knew we had multilingual attendings here. And that was incredibly important for me. And it made a very big difference in the transition. I think it can be difficult if you feel like you're the only one in any given circumstance, but especially during residency, and especially if maybe you're at places that are a little bit, I don't want to say resistant, but less open to change. So really consider that and think about, outside of medicine, what are the things that are important to you? Is it important to you to be able to walk outside and have your pick of queer-friendly restaurants to eat at, things like that, because that will make a difference in your rank list. And sometimes the location that you pick or that you enjoy the most might not be that flashy, location. It's going to be the location where you feel like your identity is mirrored in your patient population. So absolutely something to consider, and it can very much, bump a place up or down for you depending on what you want, even outside the hospital walls.
I definitely echo that. So I'm also half Black, half white. And so that identity was really important to me. And so I wanted to be at a place where I was surrounded by like-minded residents that looked like me, similar, attendings that look like me, patients that look like me, and had similar backgrounds. As a underrepresented minority in medicine, literally by definition, you are going to be underrepresented. And especially in emergency medicine, we have one of the biggest disparities in that we treat one of the most, diverse patient populations, but our providers do not reflect that. And so you might be the only one. But I think it's important to ask yourself if you're okay with that. You might be, you might not be. Either way is completely fine. If you are okay with it, ask yourself, are you going to be kind of the token minority of this program? Basically, are they going to come to you with every question they have about Black people? Are you going to be expected to lead every single pipeline effort, even though you're actually interested in toxicology? So just know that if that is the case and you're the only one, make sure that you're not in that situation unless that's the situation you want to be in.
Great, thank you so much. I really appreciate that transparency and willingness to share. I think these are things that often don't come up in interviews and even sometimes in like social gatherings with the residents at a program. So I really appreciate that you shared all of that with us. I think that kind of leads into a question that we got from student William. I think this is kind of an important question. Thinking about identity, thinking about finding community in your residency, how and really in addition to what is presented to you at an interview, how do you identify support systems when you're a resident? And I suppose that could be within your program, external to the hospital. Dr. Ely talked about wanting to make sure that the place that you were going was did have places in public that you could go to that were going to be sort of safe and a good community. But once you get there, or before you get there and you're ranking programs, what about finding support systems? What can you advise about that?
I would say it's as simple as being able to reach out to that program director or that program staff and ask for resources and have them be receptive. Even if you have not yet matched into their program, can you reach out and ask, hey, what are the resources that are available for me to transition to that area? So I'd never lived here before. I don't have anyone in this area, but it was important to me to locate resources as a mother, resources for housing, community resources such as churches or anything like that, and for them to be receptive and say, oh, I can connect you with someone if I don't know. We've never really had a single mother in our program. I don't really know, but let me find someone who has the answers. So knowing that they're responsive, I think I would do that before even matching into a program, going into it by asking the questions that you want answered, and kind of gauging that response. And if they're not really excited about having you, they won't be that excited about connecting you with your needs. And that's not a place you would want to be. I think it's as simple as that for me.
I think in terms of support, that's a great question. I think the reality is that only about 7 to 8% of faculty across all of our medical schools are URM. So it's important to keep that in mind, because very few occasions you're going to have more than 10% of URM faculty in your residency program, right? And so unless you purposely go to a program affiliated with an HBCU, and I'm really going to say, or go to Puerto Rico, because most HSIs, Hispanic Serving Institutions, were not designed with the same intent as HBCUs, you're not going to have 25 to 30%, even in communities like Newark, the Bronx, or even New Mexico. So I think it's always important to keep that in mind, but also aspire that if you wanted that experience for yourself, it's going to require that all of us become faculty to afford that to the next generation. But that's why organizations like SMA, LMSA, these diversity committees are especially important, because those are the forums where you could come together and say, like, you know what happened to me last week, and feel comfortable talking about it and ask for guidance on how to address it. And then the third support thing I would say is never limit yourself to the faculty within in your own department. The relationships you develop with faculty in other departments can really facilitate your success, right? And especially in emergency medicine, it's all about team building. So never feel like you have to be restricted in terms of advising or mentorship from your EM faculty. Reach out to surgery faculty, reach out to ENT, OBGYN. To be totally honest, I would even argue for myself, some of the greatest mentors I've had were outside of my department. So definitely keep that in mind, because I think the three things I just mentioned can help build a more supportive environment for you.
I love that. I would even say reach out to residents, that aren't in your department. So we have a Black resident council here that includes residents from all fields. And that's a great support system for our underrepresented residents. So in addition to, AAEM JEDI, we're here for you guys. So we're a support system in general. Yeah.
I think very important to reach out to the residents. Like Ariel was saying, if most residents will be happy to talk to you about these things and happy to pass on the resources that they have come across, because they aren't always easy to come across. And I would argue that if you are reaching out to a program and the residents are hesitant or don't have resources to share, that would be a red flag. And also remember that there are things that during interviews, the residencies cannot ask you. That doesn't mean you can't ask them. So if you have children and one of the big things that's important to you is what sorts of access to childcare do we have? Are there other residents in the program who also have children? Things of that nature. Reach out to those residents, because more often than not, they're going to say, oh, hey, we have this preschool that's affiliated with our program that a lot of people use, or, not a ton of us have kids, but those of us who do, we have a WhatsApp and we all stay in touch. So really look for those types of things, because that sort of support and that sort of willingness to share is a really positive sign, and I think helps a lot with the transition.
Great, thank you. I think as we sort of move toward the latter half of our program, I did have one question from a student that I wanted to just lift up to the panel. This question comes from Anne, who's asking, what can we do to stand out as an international medical graduate applicant?
I think I have to answer this question. I might be the only IMG on this call. I think for me, it was just kind of knowing what made me unique and knowing my value. I think that because I was an IMG, I had a lot of hesitancy about applying, about interviewing. I came in feeling like a sense of Black, but then I had to go through and look at my experience and the things that I'd done and be able to talk about yourself. I'm not really someone who likes to do that. I don't like to brag, but you do want to come with your best foot forward. You want to know what you can offer and know that your experience is valuable. And being willing to sometimes to go move out of the country to a place that you'd never known. I'd never been outside of the state of Arkansas. That shows a willingness to do whatever it takes to kind of meet your goals. And I think being able to come to the table and say, well, this is what I offer. I will work hard. I will overcome those obstacles. I will do what feels uncomfortable. I think people value that. And so tell the truth, about your choices, why you chose to do that and why it has been beneficial, or, if not, how you kind of overcome that obstacle or that challenge of having to, go to an offshore school and then now come to residency in the States. So just be honest, share your journey and share what's unique to you.
Great, thank you so much for that. I think the last question I want to ask our panel, and then we can move towards the sort of take-home points, would be, if you had, like, thinking back to your rank list, I know I personally made, I didn't make a whole lot of changes towards the end, and I don't think I really had, like, having really, like, spent 100% of my brain thinking about it, especially in those last couple of days before the rank list was officially due. If you had to go back and change anything about your rank list now, knowing what you know having been in training or done with training, is there anything you would have changed? Maybe the answer is no, great. But if so, or if not, what can you tell our students about that?
I can say without hesitation, I absolutely would have moved my program up. And a lot of that just comes from the realization that I am better suited in a community setting versus an academic setting. And then I also think not focusing so much on the name of the place. It's very easy to say, oh my gosh, I got an interview here. It's this, you know, has this big name. I have to rank it really high because it has this big name. And then you sort of wind up ranking places in an order that maybe necessarily doesn't fit with who you are and what you value. So just because somewhere is a prominent name doesn't mean that it's the place for you, and that's okay. Your rank list is a reflection of your personal values and your professional goals. So don't be afraid to modify your rank list based on that instead of relying so heavily on the name or the prominence of a place. I think you'll only be better off for honoring who it is that you are and what you want in your rank list.
I would agree with that too. I think that it kind of comes back to what we talked about in the beginning was, you know, what really has a good fit. And I think when it comes to your postgraduate education, in some ways, all those factors are even a little bit more important because, you know, most of us are a little further in life. You may come in and have a significant other or have a child or whatever. And so things such as safety of the neighborhood or you know, local school systems or any of that may play a bigger role. And so, because I've noticed that, you know, especially with being here in St. Louis, how many of our residents have come here and, you know, really stunned at how they kind of fell in love with the city and how they never ever thought that they would ever want to settle down like in the Midwest because we don't have mountains and we don't have the coasts and stuff. But, you know, I think they're at a different stage in their life. You know, I think students will be willing to kind of go for med school, you know, more freely based on location than maybe in residency because of where you are in your life. And I think that it's also a different kind of experience. I mean, you really are working a lot more hours and you know, medical schools now I think are a little bit kinder and gentler and put more emphasis, thank gosh, on wellness. And when, you know, back when I was in you know, in training, it was before the 80-hour work week rule kicked in. And so you had these obnoxious hours that, you know, really when you thought how hypocritical it was that you're trying to teach, you know, physicians to be kind and compassionate, yet they weren't compassionate to you in the way that you had to work. And some would say, well, it's still kind of the case. I mean, we still work 80-hour weeks sometimes on your off service rotations, but things are better. And I think that, you know, but you're going to be with that class will be a tight knit group for you. They will be your main outlet. But I also think you should try to maintain as best as you can relationships with your non-medical friends. I love the fact that I've got friends that I can, you know, that don't take me as seriously as like my residents and other people. They just, you know, when he gets tired, he asks me a medical question. He's like, I want it short. You always go on too long. Just tell me what this is. And, you know, that kind of thing. I love having a friend that can tell me that, you know, and just be honest. So, you know, keep your non-medical friends as well.
One thing I would add is don't try and play the game with your rank list. Stay true to yourself. You as the applicant, even though it doesn't feel like it, you actually have the benefit over the program. So that's how the match works. You know, through that crazy algorithm, it does give the benefit to the applicant. So don't rank a place higher because they tell you they're going to match you. My personal story. So one place called me, left a voicemail and said that I was ranked to match. I put that as my number one. I did not match there. So, you know, A, don't trust anybody, but B, just really create your list for yourself, not for anybody else. Don't create it based on, you know, what programs you think like you. Create it where you think that you'll be happiest.
Thank
I
you.
hope everyone does understand that algorithm. It really is the case. You know, I've had a couple students that were kind of doubtful about that. They were wanting to rank a place they thought they could match in the best. And I said, no, it's put your fantasy programs at the top. If you really love a place, you know, mark them number one. That could be the place you go. So.
That's right. Shoot for the stars, whatever that looks like for you. Well, thank you so much, everyone. I wanted to thank all of our panelists. In the last couple minutes that we have together, I wanted to just have a little bit of time for our panelists. If you have any take-home points that you'd like to share with our audience, why don't we just jump right in and do that?
I think so much is, finding the personality of a program. So I knew that I would not do well in a program that was, very intense, super condensed. You had to kind of constantly be studying. I knew that that's just not what I would have strived in. And so, UCSF was a great fit for me because, like I mentioned, it was, warm and fuzzy, super supportive. Yes, we had the academic affiliations and all those were available to you, but it wasn't kind of forced onto you. So just learn about the different programs' personalities and really view them that way as personalities.
I think the most important thing is really figuring out what is important to you and knowing that it's okay that things are important to different people. If being close to your family is the most important thing to you, then your rank list should be generated based on that. If getting into fellowship and being a large academic center is what's most important to you, then create your rank list based on that. If you're sunshine and rainbows and you like the beach, create your rank list based on that. But know that there's no one size fits all for how to make your rank list, and that's okay. That's part of what makes this whole process work, is that we all value such different things, and don't let your decisions be swayed because of someone else. You may have classmates who say, well, yeah, I really want to be at a 4-year program, and that's great. That may be for them, but if that's not for you, that's okay. And just remember that, and don't hesitate to reach out when you're generating your rank list. Reach out, ask questions, because there are always things after interview season that you think about as you're comparing everything. So reach out to these places, reach out to residents so that you can get answers to help you sort of solidify what it is that you want and where you think everyone should be on your rank list.
I think the parting words I would say is just, I think it's been a difficult 2 years because of COVID and a lot of the experiences that everyone has gone through. I know that, I feel for our residents and that, some of their kind of social life was kind of abbreviated because of COVID, and they didn't get to kind of do the normal things that you get to do. And hopefully that's coming to an end. But I would have to say, and probably a lot of you, because you're in medical school, have experiences as well. I in a lot of ways, I feel like these 2 years have actually made me more inspired to be a physician than ever, because I think of everyone that I've worked with, including our nurses, our techs, our unit secretaries, our engineering people in the ED. We all are working together towards a common goal, and I really think it kind of shows why we're doing this all. And so stay positive. I would not even stay positive. I would just say I think the best part is coming up. I think you're going to love it. And now that you're kind of over into that next stage, I think you're gonna have a sigh that you really have made it. And residency programs are going to work hard to help you get through your training and do it well. And you're going to do wonderful. It's been a long path, but you've accomplished it to get where you are now, and you're going to continue doing that as well. So I wish you all the best of luck.
I would just add, never forget how accomplished and successful you are. As you're thinking about all this, realize that we're all here because we want to recruit you to our programs. And the match is called the match for a reason, right? Take the time to reflect, think about what you want your next 3, 4, 5, 6 years to be like. That's going to be personally, professionally, and academically satisfying. And then after that, you're going to have to be faced with the same question: where do you want to work, right? This is just a part of this longer process of being a part of medicine. but know how successful and accomplished you are. And we would all really be happy if you reached out to us, applied to our program, or joined our communities.
All right, great. Thank you so much to our panelists for all the things that you've shared with us, for your expertise, your experiences. I will just in the last couple of minutes, I'm going to post in the chat for our audience. Please plan to attend future JEDI section meetings and webinars. Our plan is to have another meeting in March, and that is going to be a discussion about dermatologic presentations on different skin tones in the ED. So we will try to kind of break up some of these sessions with some clinical topics, general JEDI topics. It's actually kind of an open thing, so we are absolutely open to suggestions. Please feel free to reach out to any of us if you have questions. Like Dr. Brown said earlier, like the JEDI section really is here for you. It has definitely been an immense source of support for me in trying to really lean more into this type of work. And so this really is like a great community to have found myself in. So to register for any of our upcoming meetings, webinars, to get information on anything else that's coming up in the JEDI section, just check out that link there. You can register for sessions there as well. So that'll kind of be your one-stop shop for everything. Thank you again, everyone, for joining us. We look forward to seeing you again very soon. And this now ends tonight's program. Great. Good night, everybody. Thank
Thanks.
you.
Bye. Good luck on your in-service exams tomorrow. All right.
Much. Let's hope it goes well.
Yes, it will. Bye-bye.
Good night.